Hi, welcome everyone. We're going to go ahead and get started. Welcome to the Simon Searchlight Virtual Family and Research Conference for SETBP1. We're very happy to have you with us. Today's first talk is going to be the Simon Searchlight SETBP1 registry update by Dr. Bain. And Dr. Bain is an associate professor of neurology at CUIMC in the Division of Child Neurology. Dr. Bain completed her MD and PhD at Rutgers, New Jersey Medical School and studied developmental brain injury. She continued her training in general pediatrics at University Hospital in Newark, New Jersey, and Hackensack University Medical Center, where her clinical research focused on studying autonomic dysfunction in children with autism spectrum disorders. Dr. Bain subsequently completed her child neurology residency at Columbia University Irving Medical Center with research interests in the neurological outcomes of children undergoing extracorporeal membrane oxygenation, or ECMO, as well as neurodevelopmental disorders such as autism. She's interested in genetic causes of neurodevelopmental disorders associated with global developmental delay, intellectual disability, cerebral palsy, autism, and movement disorders. She sees both inpatient and outpatient pediatric neurology patients and provides programs for neurodevelopmental disabilities, neurogenetic disorders, as well as follow-up clinic for ECMO survivors. She is the lead investigator on studying the natural history of neurodevelopmental disorders associated with RNA binding proteins and also works closely with Simon Searchlight. So here's Dr. Bain's presentation.
Good afternoon. My name is Jennifer Bain. I am a child neurologist at Columbia University, and today I'm going to discuss the results of the SETBP1 registry in Simon Searchlight. Simon Searchlight is a nonprofit project that studies the genetic causes of neurodevelopmental disorders, such as SETBP1. They collect detailed medical and behavioral histories, along with blood and saliva samples. Searchlight will synthesize all this information provided by families like you and share that information back with families like you. Searchlight also freely shares this data and these samples with qualified researchers. The overarching goal of Simon Searchlight is to connect patients from around the world with genetic causes of neurodevelopmental disorders and to promote better understanding of these genetic changes. Simon Searchlight first started in 2011 and focused on families living with one specific genetic change. At that time, participants traveled to study centers and provided medical, behavioral, and neuropsychiatric data to researchers. The project has massively expanded with success, and today Simon Searchlight proudly supports more families with more than 100 different genetic changes and allows them to participate in the comfort of their own home. Data is collected about the individuals with the genetic child, as well as parents and siblings if available. First, the clinical genetic laboratory report will be reviewed by a clinical genetics team to assure that the individual does in fact have a likely pathogenic or problematic genetic variant, and they will see whether it has been inherited from parents or is seen in the siblings. An initial phone call interview will obtain a detailed medical history interview occurring at enrollment, as well as an adaptive functioning interview using the Vineland Adaptive Behavior Scale. Online surveys will then be assigned to individual families enrolled, including obtaining information about seizures, behavioral, social, and developmental skills. More targeted questionnaires can also be used for individual genetic groups as well. Simon Searchlight also collects information over time and will annually obtain information about these individuals to understand longitudinal changes. Today, I will be presenting information from the SETBP1 registry provided by families like you. This information would not be available to present today or available to researchers to understand SETBP1 without your participation, so thank you. The Simon Searchlight registry at this time has 42 individuals who have registered with possible SETBP1 mutations. I'll use the word mutation, but it also can be interchanged for the word variant. 32 individuals have submitted their labs to be reviewed. And at this time, 21 have been determined to have pathogenic or problematic or likely pathogenic, likely problematic gene changes. And of those 21, 14 individuals have completed the medical history interview. An additional 3 participants with different types of variants have also completed the MHI. But because we're just not sure whether or not those are specifically pathogenic or likely pathogenic, we call those variants of unclear significance. We're not going to be including them today, but they are being captured in the Simon Searchlight Registry. Today, I'll be describing the 14 individuals, which include 4 females and 10 males, and their ages range from 8 months to 11 years of age. 21 individuals have submitted laboratory reports that show genetic variants within the SETBP1 gene. You may not entirely understand what a variant is or a mutation. How I consider it is a typo in the genetic code. And it's this typo or change in which there's actually a problem, and it causes a problem with the function of SETBP1. What we see in our registry is that 21 individuals actually have different types of typos and different types of changes in their genetic code. For example, a few individuals have one specific letter change. These are called missense mutations. And the letters and the numbers tell you exactly what that typo is and the location of that typo. There's a whole group of individuals who carry different genetic typos that likely are causing a problem with the SETBP1 gene. 2 individuals have small little parts of the gene genetic code that actually are deleted, that aren't even present, and probably causing a problem. And another individual also has a small portion that's substituted or changed within the genetic code. Again, as I mentioned, there are 11 other individuals with other types of variants that are not seen in the regular population, and also at this time, we're unclear whether or not they're truly pathogenic or problematic. However, we are continuing to collect all this information from all these individuals, so thank you. Today, I'll be presenting the Simon Searchlight SETBP1 medical history data. Again, this is from 14 individuals who have pathogenic or likely pathogenic changes in the SETBP1 gene. Their ages are 8 months to 11 years. Commonly, individuals who have undergone genetic testing and have been found to have problems with the SETBP1 gene have developmental and behavioral diagnoses. About half of the individuals have been diagnosed with developmental delay, and another 20% or 3 individuals have later been given the diagnosis of intellectual disability. More than half of the individuals, 8 individuals, have a language impairment, and 20% or 3 individuals have been formally given the name or the diagnosis of autism spectrum disorder. Attention deficit hyperactivity disorder, such as ADHD, has been reported in 6 individuals. And other language problems, including being minimally verbal and learning disabilities, a nonverbal learning disability, have also been noted in the population. Of note, 1 individual is non-ambulatory. With regards to other issues around the rest of the body, if we look at individuals who have eye problems or vision problems, there's a small percentage of individuals who do report being farsighted, having cross-eyed, sometimes we call that strabismus, an eye problem called astigmatism, and 1 individual who has noted being nearsighted. It's unclear. This seems like not too large of an issue, probably not something special or unique to SETBP1, but certainly is an issue that's noted in some individuals with SETBP1. Many individuals have seen child neurologists and other doctors who probably have diagnosed neurological issues. That might even be why you got your genetic testing in the first place and ultimately were found to have a problem with SEPBP1. 10 individuals, which is 71% of the individuals in the group, have been noted to have low muscle tone or hypotonia. This isn't a matter of strength or weakness. This is a matter of being loose and floppy. Perhaps when you were a younger baby, they were loose and very floppy, almost like a wet noodle when they were obtaining all their milestones. And 2 individuals actually explained that their children are clumsy. One individual has been formally diagnosed with a movement disorder, and one individual has reported having a small head size. We call that microcephaly. Since we're talking about the brain, obviously many people are always concerned about a condition called seizures when there's abnormal haywire of the brain activity going on. Only one individual out of the 14 has reported having seizures. The specific seizure type that was noted in this individual is called an infantile spasm, which is a brief jerk-like episode often noted in infancy. Now remember, we've only captured individuals up to 11 years of age, so we can't say for sure that seizures is not a huge problem later than this, but at least in the population of these 14 individuals, only one person has reported having seizures. Not uncommon, neurodevelopmental disorders are often associated with gastrointestinal issues or GI issues. So 5 individuals in the group, over a third, have reported having reflux or heartburn and perhaps have been on medication for this. As many people know, children often have multiple infections as they're growing up. And not unsurprisingly, this group of individuals, almost 80%, have noted to have ear infections, which is probably pretty similar to the regular population of children. 4 of those individuals have required ear tubes for surgery, and 3 individuals have had pneumonia. So yes, a lot of people did have ear infections, but this is a pretty common occurrence in the general pediatric population. Asking about other surgeries, aside from those 4 individuals who had ear tubes, one individual had their tonsils removed, while 3 other individuals had their adenoids removed, an adenoidectomy. 2 individuals had undescended testicles and had a procedure known as orchiopexy. 1 individual had poor feeding and required the placement of a feeding tube, and 1 individual had a cleft repair, meaning a problem in the mouth where they had a cleft palate or a cleft lip that needed to be repaired. Another concern for individuals is whether this gene is important for the heart. Looking at the 14 individuals in this group, only 1 individual did report having what we call a hole in the heart, called a septal defect, and this was noted in 1 person. Another individual also noted that there was a persistent opening in the vessel called a PDA that connects the heart and the lungs. Again, these are probably not common issues within this group. As mentioned earlier, GI issues or gastrointestinal issues is not uncommon, and 1 individual did even require a feeding tube for their growth and nutrition. In this group, 3 individuals have reported difficulty gaining weight or difficulty growing, and 1 individual has reported having a short stature. And regarding the rest of the body, looking at the genital, kidney, or urinary tract, as mentioned, there were some individuals who did have orchiopexy for undescended testicles. 3 individuals had this, and 1 individual had a missing kidney with a buildup of fluid around that kidney. So it's unclear whether or not this is a significant problem in this group, though it seems to be not too big of a problem in the group. With regards to bone and the skeletal system, only 1 individual in the group has been given a diagnosis of hip dysplasia, where the hips have not formed correctly or developed correctly and might cause hip pain or problems with walking or other motor skills. One individual also noted other bone problems. 11 individuals provided information about their current medication use. 7 individuals, which is 64%, reported providing medication to control behavior. One individual did note severe behavior concerns for which they were taking a medication. And similarly, 7 individuals did report taking medication or using medication for attention and hyperactivity. As noted earlier, GI problems have been reported in this group, and 2 individuals are on medication for their GI issues. And lastly, the 1 individual who has seizures is on a medication to control seizures. In summary, thanks to all of the wonderful information that you have provided to our group at Simon Searchlight, in summary about SETBP1, some of the common issues, as noted with many developmental disorders of the neurological system, individuals present with developmental delay, language impairment, low muscle tone or hypotonia, and some ear infections. Some of the less common issues, however, some of the issues that might be problematic for some families include attention deficit hyperactivity disorder or ADHD, autism spectrum disorder, growth issues, genital issues, GI issues, and seizures. For those researchers who are interested in utilizing data collected about SETBP1 or other genetic variants, they can be easily created a Safari account with providing their IRB approval for studying the gene and signing an agreement with Simons for collaboration. We're happy to discuss this more if you're interested. Thank you for your continued support in the Simon Searchlight Registry, as it is your information that continues to grow the scientific field to better understanding how SETBP1 affects our children and our families. Thank you for helping researchers understand this gene, and thank you for connecting with families affected by this gene. Have a nice day.
Great, and now we're going to move on to the Q&A. So anyone that has any questions about what was presented in the registry talk or anything, any questions about Simon Searchlight, you can submit questions using the Q&A button, which you'll find at the bottom of the screen. If you'd like to speak your question instead of typing it, you can raise your hand and we'll call on you, and you can use your computer's microphone. So we already have some questions. We'll get started. The first question is, I see that 8 of 14 were listed to have a language impairment. How many participants were too young to have this diagnosis?
Hi, everybody. Thanks for having me. Thank you, Haley. That's a really important question. As we presented, most of the kids that are involved, and I say kids is because we really do only have little ones involved in the registry right now with this specific diagnosis. And so, language impairment is something that it can be given to you at any age. However, some might still be on that bell curve of typical, and they might not have been formally diagnosed with a language impairment. One of the most important things and one of the biggest strengths to being involved in Simon Searchlight is that we can collect that data longitudinally. And so we can collect information and new diagnoses as the individual does get older. So if at the time of entry into Simon Searchlight, that wasn't a formal diagnosis, but a year later it is, that's really important to provide that to us so that we can collect that information. I think it's a great question. And that, I think, goes right into the second question. For individuals who have a child with SETBP1 or a family member, how do you get involved? So we're happy to speak offline with you a little bit more. But basically, as I mentioned, the first step is really just getting in touch with us. And we'll be obtaining some basic information and submitting your laboratory report is the first step. And we can absolutely go into more detail for those who are interested. Um,
Thanks. And the next question is, I see that the ADHD category only included 7 individuals. This is similar. How many are too young for this category? We
it's
see
another,
from,
yeah, it's another great question. So I think um, you also mentioned that a lot more parents probably do report this even for younger kids. I think one of the concerns as a clinician, you might often see the behaviors of inattention and the behaviors of hyperactivity or impulsivity. You might not have ever gotten the formal diagnosis of ADHD. And I think that the next panelist is going to provide some information about perhaps children who've gotten the formal diagnosis of ADHD, but likely those might be really helpful for people who do have those concerns for their child and might not have a formal diagnosis. And so I think it's similarly, as children get older, we'll see whether or not they end up getting that diagnosis, as that seems to be a significant concern within the group.
thanks.
Keep reading, Lindsay.
I just wasn't sure if you were going to read them or not, but I can keep reading. So the next question is, what's the best way to provide new information regarding my child's diagnosis?
So for somebody who's new to the group, what I would say is, as a clinician, I always tell parents who have a child with any kind of developmental concern, the best thing to do is to get a nice bound notebook in our technology dependent world and keep everything in there so you can easily reference back to prior evaluations and all your doctor's visits that you've seen over the years and your IEPs and evaluations. And you can easily go back. That way, when you first sign up for Simons, you have all that information ready to go and really easily accessible. If there is new information, you can absolutely reach back out to Simon Searchlight. However, every year we will be sending out surveys and questionnaires to collect new information, perhaps with new diagnoses that you've been given.
Thanks. And this next question is a tough one. So I'm not sure if we have a great answer for it, but for the individual presenting with infantile seizures, are you able to comment on the mutation subtype? Did it resolve after a specific age and or after AED treatment?
That's a wonderful question and an important question. I don't have the answers for you, but what I'd like to do is go back to the Simon Searchlight group, see what information we can put together to provide for you to answer those specific questions. But thank you. That's a really important question.
And I'll just say, because I know that the person that asked that is a researcher, that a lot of that information is likely available if you do access Simon Searchlight data. Yeah. So the next question might actually be a good one for Caitlin, who I believe is online to tackle, but this question is it possible to reach out to those 42 registrants and ask them to complete the medical history portion of the program? We need more data as the sample size is very small.
Yes, and we actually already do reach out to people as part of our new website. There's an automated reminder system that's built in. So most of them have been reached out to at least a handful of times, but sometimes the best push is from the family groups themselves, we've learned. So it's good to always encourage each other to keep up with your registration and surveys as well. But we do continue to remind them to finish, so.
Thank you. The next question, do you track impulsivity? Do many children show impulsive behaviors, particularly impulsive aggression?
So what I'll answer about that is we don't have necessarily the specific tools to track that impulsive behavior. I'd say clinically as well as from a research perspective, it can sometimes be difficult. One person's idea of what impulsive is might be different from another. And so we don't have a specific tool being tracked right now. If that is something that seems to be particularly important in the group or specific to the group, I would note that Simon Searchlight will work with family groups or researchers who are interested in specific behaviors or specific concerns and say, maybe this is something more that we need to probe about. And that is something we could potentially inquire in the community to say, is this something of large concern that certainly should be investigated further? Thank you for that question. To interface with us, I'll let Lindsay answer that one.
Yeah, I was just typing a response. So I'll give you very specific information, but for anyone online that's interested in learning more about how to access Simon Searchlight data, you do have to be a qualified researcher with an IRB, but you go to a website that's just base.safari.org and you sign up with your institution information, and then you can apply to access our resources. But again, I'll, Rodney, specifically to you, I'll follow up with you one-on-one.
Yeah, and I'm happy to, with my other hat, you know, I've definitely been on the other side to access that information as a physician scientist. So if you have any like real-time questions, I can absolutely help you as well if you have any difficulties or navigating that system.
Yeah, and the last point that I'll make is that we have a resource on simonsearchlight.org under For Researchers. That's an infographic that kind of outlines the process of how to set up an account and how to access data. And that's something that both researchers and families can get access to. And so if families are in touch with researchers who are interested in accessing Simon Searchlight data, they can just link them to that infographic, and it's a really helpful resource. Okay, the next question. Our adopted daughter exhibits a lot of the major disabilities. She's come a long way with additional trauma. It's super difficult to teach her anything logical. Took her a good number of days to close the car door, for example. Have any other parents had similar issues? And this might be a tough question for us to tackle specifically here, but I will say that at the end of this meeting, after all the presentations have wrapped up, we are going to kind of close things down for the researchers and any clinicians on the line and open up for a forum for all of the family members to connect with one another. So you'll be able to turn on your cameras and unmute your mics and interact with families. So that might be a great opportunity to get that help from some of the other parents. And then this next person just wants to know if they were included in the Simon Searchlight data. And I will say, if you have questions about whether or not you were included, you can absolutely reach out to me. My email address is available in all of the registration, but if you filled out everything, you're most likely included. I don't know, Dr. Bain, if you want to go over again those 3 people that were not included, but there are just some special cases there.
Yeah, so you know, there's obviously a sequence when individuals come to Simon Searchlight. They say, I believe that we're affected by SETBP1. Here's our information. So the first step is to come to us. The second step is to provide that information so we can go through that to say, yes, we think this is the cause, or no, we're not really sure, or no, we're definitely not sure. But if you've made it to genetic diagnosis and you've made it to Simon Searchlight, more than likely there is a concern, a significant suspicion that that's the cause. So the first step would be giving the clinical genetic report. The second would be, yes, if going through the medical history interview and providing all your information. And then intermittently, especially before family meetings, the goal is for Simons to put all that into a nice picture and then to put it into a presentation. So there very likely might be a few people who either didn't finish it before that data was kind of analyzed, or perhaps it was one of those individuals that was, well, we're not 100% sure right now. So I think the goal, right, if you do have a specific question, obviously we don't want to provide your personal information right here in front of the group, but we're happy to let you know if you were included in that information. But it is a rolling enrollment, so we get information every single day. Somebody might have provided information even this morning, and that would not have been included in today's. I hope that answers your question.
Thank you. The next question, in your experience, have you seen growth in terms of abilities over time? And I think this is related, so I'll go ahead and read it. They say, to that extent, our daughter managed to read and write in roughly 3 years, but still has issues in understanding the content.
So I think the information that I'm trying to share with you today really is the information that Simons has gotten thus far. And so unfortunately, the information I have isn't really looking over time. It's just kind of, here's the basic information that we've collected. What I would say is that in general, neurodevelopmental disorders children continue to gain skills, perhaps slower than typical. And I think that's really the importance of being involved in a registry or a formal study, so that we can monitor individuals over time, but also the group over time as they get older. As you saw from earlier, most of the individuals here are still young. And so they're still continuing to have a lot more development and growth over the years to come, and we hope Simons Searchlight can be a part of collecting that information and sharing that information back with you.
Thank you. And there are no more questions, so I'll give it just one more moment in case anyone has last-minute questions before we move on to the next presentation.
Thank you for your time. If you have any burning questions, I'm available even afterwards. Have a nice day.
Thank you. Okay, so during our next presentation, we're going to have Dr. Sid go over SETBP1 and ADHD. And many of you are likely familiar with Dr. Sid, but Dr. Sid Shrivastava is a pediatric neurologist at Boston Children's Hospital specializing in neurogenetics. His research involves studying different genetic causes of neurodevelopmental presentations, such as autism, intellectual disability, and cerebral palsy, using the multimodal approach of gene discovery, cognitive behavioral phenotyping, and biomarker identification. At Boston Children's Hospital, he provides care to children in a variety of neurodevelopmental and neurogenetics clinics. And so here is Dr. Sid's presentation.
Today I'm going to talk about attention deficit hyperactivity disorder, or ADHD, as it relates to SETBP1 disorder. Here is an outline of my talk. I'll present some background information. I'll talk about the diagnosis of ADHD. I'll cover treatment approaches, including what to do when medication approaches fail. So first, let's cover some background. We're still learning more and more about the function of SETBP1. What we know is that it encodes a protein which binds to the promoter regions of different genes that are important for brain development. This explains why disruptions to this gene lead to a spectrum of neurodevelopmental disorders. These include intellectual disability, attention deficit hyperactivity disorder, autism spectrum disorder, hypotonia, delayed motor development. I started analyzing data from the Simons Searchlight Initiative. There are 11 participants with SETBP1 disorder with data that I could analyze. In terms of the different types of variants represented by these 11 participants, 6 had nonsense misspellings, 2 had missense misspellings, and 3 had frameshift misspellings. This graph shows adaptive standard scores from the Vineland on these 11 participants. Think of adaptive skills like self-help skills. There's an overall adaptive score, a score for communication, socialization, daily living skills, and motor skills. The overall adaptive score was 66. A score of 100 is the mean, and 1 standard deviation below the mean is 85. So 66 is roughly 2 standard deviations below the mean. Communication and socialization were relatively higher. Daily living skills and motor skills were relatively lower. I looked at the prevalence of autism that was self-reported among participants with SEPBP1 disorder in this cohort. It was about 10%. Similarly, I looked at the prevalence of ADHD that was self-reported among participants with SEPBP1 disorder in this cohort. It was about 45%. In fact, in a prior medication survey completed by some families, 80% of the respondents, so 7 out of 9 who responded, said that hyperactive, impulsive, and/or inattentive behaviors or processing speed were important targets for medication therapy. So I think it's really, really important to talk about ADHD when it comes to SEPBP1 disorder. We don't have a specific targeted treatment for SEPBP1 disorder yet, but we do have some good approaches to treat ADHD, which may improve quality of life. First off, how do you make a diagnosis of ADHD? ADHD is characterized by inattention, distractibility, hyperactivity, impulsivity. The behaviors start in childhood and they're present in multiple settings, so school and home. They result in performance issues affecting social environment, educational environment, the work environment. And you really have to take into account a child's developmental level. For example, if you have a 10-year-old child, but they're developmentally at the 5-year-old level, then their attention and focusing should also be at the 5-year-old level. There are 3 subtypes of ADHD: a predominantly inattentive presentation, a predominantly hyperactive presentation, and a combined presentation. Keep in mind that the term ADD is no longer in use. There are 9 core types of inattentive symptoms. These include a child who often fails to give close attention to details or makes careless mistakes, a child who often has difficulty sustaining attention in tasks or play activities, a child who often does not seem to listen when spoken to directly, and so on. I won't go through each of these, but they're listed on the slide. There are 9 core types of hyperactive impulsive symptoms. So these include a child who often fidgets with or taps their hands or squirms in their seat, who often leaves his or her seat in situations when remaining seated is expected, who often runs about or climbs in situations where it's inappropriate to do so. Again, I won't go through each of these, but they're listed on the slide. The DSM-5, which establishes guidelines for different neurodevelopmental diagnoses, has established diagnostic criteria for ADHD. In terms of age of onset, there must be several inattentive or hyperactive impulsive symptoms prior to 12 years of age. These symptoms have to be present in 2 or more settings, such as the home and school. Individuals who are younger than 17 years must have 6 out of 9 inattentive or hyperactive impulsive symptoms. Individuals 17 and older only need to have 5 or more symptoms. These symptoms have to be present for at least 6 months, and they must exceed the expected level of behaviors based on the child's developmental age. These behaviors have to interfere with or reduce the quality of social, academic, occupational functioning. And these symptoms are not better explained by some other disorder or diagnosis. ADHD is a clinical diagnosis. So this involves getting a detailed history to evaluate behavioral symptoms. Often parent-teacher rating scales are needed to get evidence from teachers. So these scales include things like the Conners, the Vanderbilt rating scales. We often use DSM-5 criteria before making a diagnosis of ADHD. Of course, it's important to think about other things that may be going on before making a diagnosis of ADHD. For example, is there vision or hearing impairment? If you can't hear or see as well, you can appear unfocused, inattentive, hyperactive. Are there sleep problems? Poor sleep is associated with a variety of behavioral and other problems and can present as ADHD in some cases, SEPBP1 disorder being no exception. Is there a thyroid problem, such as hyperthyroidism? Usually there are other symptoms that go along with this though. Could there be seizures, specifically absence seizures? A good history will help indicate if this may be the case. So now let's talk about treatment options for ADHD within SETBP1. First of all, what are the goals of treatment? So here are the goals that I think are really important to keep in mind for treatment. Decrease frequency of disruptive behaviors, improving self-control, self-esteem, improving safety in the community, at home, improving independence in self-help skills and schoolwork, and improving relationships with parents, siblings, peers, teachers, and everyone else. There are two approaches to treatment, and often both are necessary. There are non-pharmacological interventions, such as parent training, behavioral therapy, educational accommodations, social skills training. If behavioral therapy is not effective or ineffective, medications may be necessary. There are three main classes of medications for ADHD: methylphenidate products, which are stimulants, dextroamphetamine products, which are also stimulants, and non-stimulant medications. Stimulants are the first-line medications for ADHD. However, we also have a few non-stimulant options available to us. With the diagnosis of ADHD, I usually start with behavioral approaches. Here are some general survival strategies for managing ADHD. I'll go through each of these briefly. They include things like modifying your expectations. So being realistic about what your child handles well and not well. Identifying success. So if there's a situation your child does well in, amplify that situation. Get moving, so encourage physical activity on a regular basis. Allowing fidgety behavior when you're working or when your child's working, so that may help your child pay attention in some cases. Applying the breaks, so scheduling time for breaks after working on an activity for a certain period of time. There are also some behavioral modification techniques that may be helpful. I'll go through each of these briefly as well. So this includes things like using simple, specific commands that are one step, not multi-step, and that are not stated as a question. Using positive reinforcement, so giving rewards for good behavior immediately after the behavior. Token economy, which is providing awards after a child accumulates a certain number of stickers or stars. Consequences for negative behavior, so taking away a reward such as a toy for unwanted behavior. Timeout, and this is really 1 minute per age in a quiet, non-distracting, set-aside area. Using visual or auditory aids like a timer that dings to really help your child stay on task and to help with transitions. Behavioral therapy is an approach that involves structured discipline to reward desired behaviors, such as following directions, and eliminating undesired behaviors, such as losing homework or losing a toy. For kids under the age of 5 years, behavioral therapy is indeed the first-line treatment for children with ADHD. I've included a link below from a parent-friendly magazine that talks about this in a little bit more detail. Behavioral parent training is another behavioral approach for ADHD. This teaches parents skills on effective, productive interactions with their kids. The goal is to strengthen parent-child relationships and build long-term strategies for behavioral management. These programs require 10 to 20 sessions, each focusing on a specific technique to address a problematic behavior. Again, there's a link below that talks about this in more detail, and this is from a parent-friendly magazine. Behavioral therapy can take time, on the order of months or longer, but if the symptoms of ADHD do not improve, then medications may be necessary, either alone or in combination with behavioral approaches. So treatment may require a trial and error approach, starting with one class of medication and switching to another because of poor response or side effects. We often start with stimulants as the first-line treatment of ADHD, regardless of whether it's due to SETBP1 disorder or another cause. The question is, are stimulants effective for ADHD? And the answer is yes, for the most part. There's a key study early on that showed that 70% of children show improvement on stimulants. This is the so-called multimodal MTA cooperative group study. Keep in mind that this wasn't specific to SETBP1 or other genetic syndromes. It was a heterogeneous group. We have no better treatment options for ADHD at the moment. There are some simple principles regarding stimulants and starting stimulants. I recommend a start low and go slow approach, especially because the metabolism of kids with SETBP1 disorder may be different. Some kids may have higher metabolisms, other kids may have slower metabolisms. I recommend waiting at least 1 week before deciding whether a new medication or dose change is effective or not. Avoid the temptation to stop a medication early on unless there are serious side effects. Also, try to start on a weekend or a holiday so you can see directly if there are any side effects or see the effects, the efficacy on your own. Stimulants can have various side effects. These side effects include appetite suppression, sleep problems, irritability, rebound symptoms as the medication wears off, headaches, stomach aches, compulsive behaviors, unmasking of tics. This does not mean that your child will develop all of these symptoms. This is just meant to illustrate the range of possible side effects. Sleep and appetite changes tend to be among the more common of the side effects that you see with stimulants. You do have to periodically monitor heart rate and blood pressure while being on a stimulant medication. Here are some common questions that people ask about stimulants. For example, some may ask about stimulant use in cardiac monitoring. So stimulants are contraindicated in individuals with structural cardiac abnormalities. So if your child is having echocardiogram or ultrasound of the heart that showed that there's a structural heart defect, then stimulants may not be a great idea unless you have approval from the cardiologist. Otherwise, people on stimulants undergo routine heart rate, blood pressure monitoring. Another question relates to whether stimulants cause short stature. So stimulants can cause appetite suppression, which may lead to weight loss. The good thing is that you can address that with simple measures such as boosting caloric intake with peanut butter, smoothies, things like that. A final common question is about stimulants and tics. So tics are not caused by stimulant use per se, but they can be unmasked with stimulant use. And in general, it's okay to have tics and also be on a stimulant. Choosing which medication depends on your preference for duration of medication, how your child can take the medications. Within each class of medication, there are short-acting forms, which last about 3 to 6 hours, and long-acting forms, which last 7 to 12 hours or so. There are pill options, which you can't crush or chew, capsule options, which you can open up and sprinkle onto food, like yogurt, applesauce, chewable pills, liquid solutions, and patches, which you can apply onto the skin. So let me go through these options, and I'll start with the methylphenidate products. So keep in mind that this list is not meant to be exhaustive, as there are new formulations which come out every year, every few years. So starting with the methylphenidate products, and we'll start with short-acting methylphenidate products. So this includes Methylene, Ritalin, and Focalin. Methylene comes as a chewable tab in a liquid, and the others are regular tabs. Take about 30 minutes to kick in. They last 3 to 6 hours, 3 to 4 hours, somewhere in that ballpark. And they usually are given twice a day, though in some cases you can give them up to 3 times a day. Intermediate acting products include Metadate ER, which comes as a pill that has to be swallowed whole. It takes 1 to 2 hours to kick in and lasts about 8 hours or so. It's usually given once a day, but you can give it twice per day as well. Long-acting products include Ritalin LA, Metadate CD, Concerta, Daytrana, Focalin XR, and Quilivant XR. Ritalin LA, Metadate, and Focalin XR comes as capsules that you can open up and sprinkle onto food. Daytrana comes as a patch. Quilivant comes as a liquid. Focalin XR has the shortest onset of action. It kicks in within 30 minutes or so. And in general, these long-acting medications last anywhere from 7 to 12 hours per day, depending on the exact medication. And they're usually given once a day. In terms of amphetamine products, so this is a different class of stimulants. There are short-acting versions, intermediate, and long-acting versions. The short-acting versions include Adderall, Zenzity, and Procentra. Adderall and Zenzity come as pill forms, and then Procentra comes as a liquid form. These short-acting amphetamine products, the Adderall, Zenzity, and Procentra, they kick in about half an hour or so. They last anywhere from 4 to 8 hours, and they're given once a day to upwards of 3 times a day. Intermediate acting products include Dexedrine Spansules, which come as a pill form, kicks in about 1 to 2 hours and lasts 6 to 10 hours, and it's given once a day, but can be also given twice a day. Long-acting products include Adderall XR and Vyvanse. Adderall XR comes as a capsule that you can open up and sprinkle onto food. Vyvanse comes as a capsule and also a chewable version too. Adderall XR takes about 30 minutes to kick in and lasts 10 to 12 hours. Vyvanse takes longer to kick in and lasts about a similar amount of time. Both are given about once a day. In most cases, ADHD can be treated without the use of second-line agents, so mainly with the use of stimulants. However, in some cases, the use of a second-line agent may be necessary. For example, there may be suboptimal or adverse responses to a stimulant. In children who are especially young, I sometimes consider starting a second-line agent first rather than a stimulant. Finally, some family members may prefer that their child not be on a stimulant for ADHD. And I've heard this from other families with ZPP1 disorder. Side effects of non-stimulant medications can vary depending on the exact medication, but some examples of possible side effects include sedation, sleepiness, dry mouth, GI symptoms, low blood pressure, low heart rate. Depending on the medication, you may have to monitor heart rate and blood pressure. Here are the non-stimulant products. There are short-acting and long-acting forms. The short-acting options include guanfacine and clonidine. These come as pills, which are given 2 to 4 times a day. Each dose lasts anywhere from 4 to 8 hours. Keep in mind that it takes a couple of weeks before you notice an improvement in symptoms, so this is different from stimulants. Long-acting options include Catfay, which is clonidine extended release, clonidine patch, and Intuniv, which is guanfacine extended release, and also Strattera, which is also known as atomoxetine. Each dose of Catfay, or the clonidine extended release, lasts 12 hours or so, and this can be given up to twice a day. The clonidine patch is applied once a week. Intuniv can last up to 24 hours and is given once a day. Strattera also lasts about 24 hours. And again, these medications take a couple weeks to build in your system, so you have to give it some time before you start to notice a change or an improvement. A common question that comes up with SEPBP1 disorder, with families with SEPBP1 disorder, is whether you can use pharmacogenomics testing to see if your child will respond to a certain class of medication. Unfortunately, for ADHD medications, there are not really published guidelines that guide dosing and product selection. And without these guidelines, recommendations with this type of genetic testing are based on other factors, such as responding to other medications. And these recommendations may not be strong recommendations either. What about non-medication options for treatment of ADHD? I know a lot of families are interested in what else can we try besides stimulants for ADHD. So I listed a few here listing the treatment, side effects, and whether they are effective for ADHD or not. Omega-3 fatty acids, which are a component of Viarin, are associated with GI side effects. Data about its efficacy in ADHD is inconclusive, although some studies have shown benefit. Meditation, depending on your child's cognitive level, if they're able to participate in meditation, doesn't really have side effects. Its efficacy for ADHD is also inconclusive. Prior studies on the use of meditation for ADHD have been of low quality. Exercise actually does seem to benefit the core symptoms of ADHD. So something to keep in mind, regular aerobic exercise if your child is able to do so. Neurofeedback, also known as EEG biofeedback, does not really seem to help symptoms of ADHD. And then if your child is able to participate in CBT or cognitive behavioral therapy, from a cognitive perspective and a functioning perspective, then for adults with ADHD, that may be helpful, but of course, more studies are needed. What about certain vitamins and minerals? Do they help for ADHD? There's one double-blind placebo-controlled study that has shown that zinc as an adjunct to stimulants may be beneficial, but not zinc by itself per se. Ferritin levels, which are a measure of iron stores in the body, are lower in children with ADHD compared to controls, but this does not mean that you should start iron if you have a diagnosis of ADHD. And in general, there is not really a lot of evidence to support the use of specific vitamins or minerals for ADHD. How about nutrition? Does nutrition impact symptoms of ADHD? So there isn't a lot of evidence that changing your diet will improve ADHD symptoms, but we do know that certain nutrients are important in general for brain health. So there's a link to a National Geographic article recently that talks about this in more detail. Multiple nutrients are important for brain health, and this includes protein, zinc, iron, choline, folate, iodine, vitamins, omega-3 fatty acids. And I've listed some examples of foods that are rich in these components: fish, oats, nuts, citrus fruits, berries, plums, sweet potatoes, other vegetables of different colors. So not saying that you should be on a diet exclusively with these things, but to diversify your diet if possible, to include some of these components if possible. One of the challenges that comes up is what to do when ADHD medications fail. What else could be going on? I'm going to present 4 sample scenarios, vignettes of individuals who are not responding to ADHD treatment. So what could be going on in these cases? What else should we consider? I just want to give a shout out to my mentor at Kennedy Krieger, Dr. Bruce Shapiro, whose slides I adapted for this portion of the talk. So the first case is a 5-year-old boy with SEPBP1 disorder and the diagnosis of ADHD based on hyperactive impulsive symptoms. He was started on methylphenidate and the dose was optimized, but there hasn't been any symptom improvement. Not surprisingly, his language was delayed. He requires speech language therapy. So this is a really simple example, but the point I want to make here is, do we have the correct diagnosis of ADHD? Not all hyperactivity is due to ADHD. Hyperactivity can be due to a cognitive learning disorder, such as intellectual disability, language disorder, a specific learning disability. If these are not recognized or treated appropriately, it can appear as hyperactivity/ADHD, though it not really is that. Anxiety can look like many things in young kids, including ADHD. Mood disorders like depression can also sometimes appear as behavioral dysregulation that can mimic ADHD. And as I mentioned earlier, it's important to consider the possibility of a medical problem like hearing loss or trouble sleeping, insomnia, that may be going on that may mimic symptoms of ADHD during the daytime. So let's talk about case number 2. Eric is a 6-year-old boy with SETBP1 disorder and a diagnosis of ADHD. He started taking Concerta, which is a long-acting stimulant, but he didn't continue it due to moodiness. He then started Ritalin, which is a short-acting stimulant, which had good effect initially. So this past year, he started a full-day program, and the Ritalin no longer seems to be effective. So what could be going on in this case? In this scenario, I think the key question is, are we observing behaviors during the peak action of the stimulant? So short-acting stimulants can take, 30 minutes or so to work, and they last anywhere from 3 to 4 to 6 hours, somewhere in that ballpark. And dosing is usually twice a day. So ideally, one would want a smooth overlap between the decreasing or waning effect of the first dose and the rising effect of the second dose. You want a smooth curve, such as the graph on the left. The situation to avoid is the curve on the right. So in that situation, the first dose of the medication is out of your system before the second dose is started. And in that case, there isn't that nice overlap between the two medications. And so this could be what might be going on in this scenario. Sometimes individuals are fast metabolizers, and each short dose of stimulant may last only 3 hours, 2 or 3 hours, much shorter than usual, 4 to 6 hours. And this may be the case for some kids with SETBP1 disorder, and actually the opposite may also be true. Some individuals may be fast metabolizers. Either way, it's really important to assess for the timing of symptoms during medication management. When are the symptoms at their peak? When are the symptoms under control? I think that's really important to know. So let's move on to scenario number 3. So Tanya is an 11-year-old girl with SETBP1 disorder. She was diagnosed with ADHD when she was 7. She started stimulants and she had an excellent response initially. So this year she started 6th grade and she's faced increasing difficulty in school. So what could be going on in this case? The first question I would ask here is, are there compliance issues? And so some of this may be dependent on the child's cognitive level. So on the parent side, sometimes parents are unsure about their decision to start or continue a stimulant in their child. They may be giving medications inconsistently, which can lead to inadequate or inconsistent treatment response or effect. If the parent is trusting that their child is taking the medication on their own, once again, this is contingent that the child is cognitively able to do so. This might also pose challenges or issues. On the child's side, the child may not want to take the medication, saying there's nothing wrong with them. Once again, this is dependent on the child's cognitive level. They may be having some side effects, and that may deter them from wanting to take the medication. And then also in higher functioning individuals, where some cases diversion may be an issue, where the child is giving the medication to others. It's really important to note that certain medications have to be taken in a certain way, and doing so incorrectly can also lead to unproductible responses. Another really important question to ask in this scenario is, do we have the right expectations? It's really important to match the expectations of the child, the capabilities of the child, with the demands of the situation. What I mean by that is, so if you have a child who's at the 1st or 2nd or 3rd grade level academically, but they're being taught at the 5th or 6th or 7th grade level, then there's a mismatch. And so whatever that level may be, the point is that if there is a mismatch in the demands of the situation and their expectations and a child's intrinsic capabilities, if there is a mismatch, that can sometimes lead to behavioral problems, including what appears as ADHD. Of course, school demands change throughout the years. So once again, depending on the child's cognitive level, if they're at a level where as they get older, compositions or chapter reading may be something that becomes part of their schedule, then as these academic demands increase, this can also unmask symptoms and need addressing. So here's the final scenario. So Becca is a 6-year-old girl with SETBP1 disorder, recently diagnosed with ADHD. Her parents were initially hesitant to start medications, but they were impressed with the initial effects. And during the titration period, they really pushed to increase the dosage. And after an initial period of improvement, she seemed to revert to her previous behaviors. So what could be going on in this case? The question I would ask here is the medication timing/dose optimized? The dose might be too high and can be titrated slightly down, which may be the case in this scenario. There are many ways to tweak a medication so that we have the right drug, the right dose, the right duration of effect, the right delivery system, and so on. And the key point is don't give up and don't be discouraged. I wanted to wrap things up with some considerations across the lifespan when it comes to ADHD. In the preschool age, the focus really is on diagnosis. Do the symptoms fit with the diagnosis of ADHD, or could there be something else going on? Safety is really important. I generally don't start medication in the early preschool age for ADHD unless there are safety concerns and or significant parental distress. In the school age, so this is the time to think about whether the child needs certain accommodations and may get by with a 504 plan, but it seems more likely that an individual may need an IEP or an individual education plan, given the neurodevelopmental complexity of SETBP1 disorder. School age is also when friendships start to blossom. Keep in mind that kids with ADHD can have social impairment because they may not be paying attention to social cues, for example. During adolescence, academics are, of course, a huge concern. And once again, this is also dependent on an individual's cognitive level. So if standardized testing is something that may be a possibility for a child with SETBP1 who's higher functioning and cognitively able to, then keep in mind that requires getting neuropsych testing, and there's other logistics before that can be approved. Kids with ADHD can be impulsive, and this can amplify risk-taking behavior during adolescence, so you have to be mindful of that fact. In adults, jobs and family are two things that come to mind. And also this is contingent on the child's cognitive capabilities. 50% of individuals continue to need stimulant medications in adulthood. Disorganization can be a challenge, which may affect both of these areas. But the good thing is that there are resources like life coaches, executive functioning coaches that may be helpful in this regard. Let me wrap things up. ADHD can be a significant challenge for individuals with SETBP1 disorder. There are a number of treatment options, including medication and also non-medication approaches. Medication approaches may and often do require a trial and error approach. The goal of treating ADHD symptoms really is to improve functioning in life, in school, across multiple settings. Finally, I would like to thank Haley Euler of the SETBP1 Society and all the other SETBP1 families, Dr. Wendy Chung and the rest of the Simon Searchlight, and Dr. Mustafa Sahin, who's my mentor at Boston Children's Hospital. Thank you.
All right, thank you so much, Dr. Sid, for that presentation. Again, for anyone that has questions now for Dr. Sid, you can enter them in the Q&A box, or you can raise your hand and we can call on you. And just a reminder that Q&A box is at the bottom of your screen. Okay, the first question here is, you didn't mention the use of Risperdal. How common is that used to treat ADHD?
It's a good question. So Risperdal is a neuroleptic medication, also known as an antipsychotic medication. It's a medication that's typically used for aggression, and it's also used for irritability associated with the diagnosis of autism spectrum disorder. So it's not a typical medication for ADHD. If a child affected has significant aggression, meaning hitting others, hitting himself or herself, targeted aggression, those type of really severe behaviors, aggressive behaviors, then it's a possibility. Usually for aggression in the setting of SETBP1 or other genetic disorders, if medications are warranted, I'll usually start with a non-stimulant option such as guanfacine or clonidine and some other options before considering a neuroleptic like Risperdal or Abilify is another example. And the reason being is that neuroleptics are effective medications for those type of aggressive behaviors, but they're also, they have a strong side effect profile. The side effects of Risperdal and other neuroleptic medications include effects on blood sugar levels, effect on cholesterol levels, the need for monitoring of blood, monitoring, doing blood work, and so forth. And so, I tend to start with medications with a less hefty side effect profile, and often will use neuroleptic medications after exhausting some other options.
Great, thank you. The next question says, can you please further explain the unmasking of tics? My son takes Vyvanse, 60 milligrams, but in the last few months, he's constantly clearing his throat, typically 3 to 4 times per minute. Our doctor added 10x, but it has made no difference. Is this typical, and should we switch him from Vyvanse, or how can we get the tic to stop?
Sure, that's a great question. So the natural history of tics is that they come and go, they wax and wane. And what I mean by that is there's going to be periods when the tics are going to be more prevalent, more significant. And then there are also going to be periods when the tics are less prevalent, less significant. And sometimes what ends up happening is that sometimes one creates a cause and effect relationship between, oh, we started this medication and the tics got worse, and we stopped the medication and the tics got better. I think we just have to be careful and acknowledge that tics on their own, there are periods when they get worse and there are periods when they get better. And sometimes there may be other factors at play. For example, stress, significant anxiety, stressful situations, transitions from one environment to another. Those kind of significant changes can cause tics to get worse. And so we just have to be mindful of that association. So I think in general, if it's, in general, I think if you can weather the storm, so to speak, meaning wait, if you have the ability to wait it out and wait some time, I think you might find that things may settle down and may stabilize and return back to their baseline without you having to stop or switch to another medication, especially if that medication is helpful if the Vyvanse has been helpful and beneficial for the ADHD symptoms, then I think waiting it out and seeing what the tics will do over time, over the next couple weeks, next couple months. And with that said, I also acknowledge that tics can be quite impairing and so forth. So there's a lot of nuance to this, but those are just some general considerations.
Thanks. And we don't have any immediate questions, but I'm going to, again, give it a few moments to see if folks have more questions. And if not, then we'll move on to the next presentation. Okay, this person writes in asking, do you ever recommend ABA therapy for ADHD?
Yeah, that's a really interesting and really good question. So typically, so ABA stands for Applied Behavioral Analysis Therapy. It's a type of one-on-one therapy in which a therapist works with the child directly. And the goals of ABA therapy are to improve communication, to improve socialization, to improve self-help skills, and also to improve behaviors. You know, in this, so typically we think of ABA therapy as being beneficial for children with a diagnosis of autism spectrum disorder. And in the United States, at least, it's often very difficult to get ABA therapy unless you have will get ABA therapy paid for through insurance unless you have a diagnosis of autism spectrum disorder. Now, with that said, though, even though insurance will often will only pay for ABA therapy with the diagnosis of autism spectrum disorder, you know, it's a good question. Can ABA therapy be helpful for other types of neurodevelopmental impairment, such as intellectual disability, such as, you know, ADHD and so forth? You know, I think it's so. I guess to answer your question, I think there's a possibility it may be helpful, especially if the therapist works on some of the behavioral components. But I think a challenge maybe is without the diagnosis of autism, having insurance to pay for it.
Thank you so much, Dr. Sid. That's going to wrap up our Q&A for this presentation. And now our final presentation will be a SETBP1 Society update from Haley Euler.
Hi, everyone. I'm Haley Euler, the president for the volunteer-based nonprofit SETBP1 Society. Thank you, Simon Searchlight and Safari, for helping to organize this meeting and for providing this venue for our families to learn and connect. Thank you, Dr. Sid, for speaking with our community, and to all of our SETBP1 families who are joining us. Our mission at SETBP1 Society is to provide support to individuals with SETBP1 disorder and their families, to promote discussion and fund research, and to bring awareness and education to the public. A key to fulfilling our mission is to collaborate with the scientific and medical communities and encourage open communication and resource sharing. We believe our organization will bring targeted treatments to individuals impacted by SETBP1 disorder by being proactive, collaborative, and up-to-date on the developments in the rare disease community. For us as an organization, when we speak of targeted treatments, we're including proven teaching methods, programs, and/or therapies that help our children learn more effectively, and medications that are customized for individuals with SETBP1 disorder. When SETBP1 Society first formed in 2017, there were not any researchers actively working on SETBP1 disorder. There were several barriers to studying SETBP1 disorder, including lack of biological models and lack of verified assays or tools to study the models. We had one mouse line that was available as frozen sperm in France, which meant there were restrictions or limitations to accessing the line, and lots of time and resources were required to grow the live mouse colony. Our organization dedicated funds and a great deal of energy on building SETBP1 disorder biological models and making them available to other researchers. With guidance from Dr. Wendy Chung, we partnered with the Jackson Laboratory to develop 2 SETBP1 disorder mouse models. One of the mouse models is currently at Dr. Rodney Samako's lab at Jan and Dan Duncan Neurological Research Institute in Houston. The other mouse model will be available in the fall. We've also worked with Dr. Carl Ernst at McGill to build neurons from patient-derived iPSC lines. And we're working with Dr. Simon Fisher at Max Planck Institute for Psycholinguistics to do something similar. 2 new opportunities have kicked off, and Simon Searchlight is developing SETBP1 iPSC lines from blood samples donated by SETBP1 families. Boston Children's Hospital has a new project where they're developing neurons from iPSC lines that they create. Both of these projects will make the developed resources available to researchers as well. Having IPSC lines at various locations can be advantageous for several reasons, including situations we currently find ourselves in, where shipping and receipt of resources or materials, even across state lines, has been restricted or limited. It's also helpful to have the line stored in different countries, as access can be restricted or limited due to institution or mailing challenges across borders. You will get the opportunity to learn more about IPSCs and animal models during Friday's general session. In addition to building the models, we focus funds and efforts on researchers studying the biological models in order to answer several questions. We need to understand the impact of SETBP1 differences on the brain, including at the molecular, cellular, and behavioral level. This will enable us to answer questions like, why does SETBP1 disorder cause attention issues? Or what pathways are impacted by SETBP1 disorder? Or what genes does SETBP1 regulate? We also believe it's highly important to identify what symptoms of SETBP1 disorder are reversible and at what stages in life. For example, can we improve self-regulation symptoms if we provide a therapy when a child is 1, 5, or 18 years of age? Or if we provide a therapy that improves attention, will it work for a 25-year-old or only for a child 3 years or younger? Questions related to reversing symptoms are currently under evaluation by some of our researchers studying the neurons derived from IPSC lines. And we plan to invest funds to answer these types of questions in mouse models as well. The SETBP1 disorder phenotype is discussed only briefly in literature. This makes it harder for medical specialists to know how to help SETBP1 disorder patients, how to properly diagnose patients, and harder for families to know what to expect for their children. We collaborated with Dr. Angela Morgan from the Murdoch Children's Research Institute to help her complete her SETBP1 speech and language study. She's a speech pathologist and professor with a deep interest in apraxia of speech and other speech and language issues. Her research includes the largest cohort of SETBP1 individuals to date. Her paper will also help expand the phenotype beyond the speech and language findings she uncovers. We also promote the official SETBP1 disorder patient registry hosted by Simon Searchlight. This registry is fundamental and one of the greatest contributions to helping our community, researchers, and medical professionals better understand SETBP1 disorder and the progression of the disorder. If you haven't had a chance to join the Simon Searchlight registry, please highly consider joining. We also have dedicated, esteemed medical specialists focused on studying SETBP1 disorder, including Dr. Sid at Boston Children's Hospital, whom you heard from earlier, and Dr. Brege van Bon, who is a clinical geneticist at Radboud Medical Center in Nijmegen, Netherlands. Their works help shed light on the challenges faced by individuals with SETBP1 disorder, and they help our society develop educational materials and ensure they're medically precise. Additionally, we plan to further invest in larger studies identifying meaningful biomarkers and endpoints for SETBP1 disorder. This is a crucial step towards preparing for clinical trials in the future. We also plan to explore different types of therapies, including drugs already approved by the FDA for other purposes, and therapies that impact SETBP1 production. But before we get to this point, we need to better understand our disease models, what symptoms are reversible and at what stages, and to validate we have the proper tools available to study these models, which you saw earlier is where we're currently investing our time, energy, and our hard-earned donations from our amazing SETBP1 families and supporters. Our strategy to achieve our goals is to collaborate with researchers and medical specialists. We want to ensure we can play an active role in advancing their research, whether that be to help fund the research, write letters of support for grants, connect researchers with other researchers, or help connect researchers with patients. We started the SETBP1 quarterly collaboration calls to help unite our researchers and medical professionals to help the research progress at a faster pace. Through the generous support of our community and through partnerships with the University of Pennsylvania Orphan Disease Center, we've helped raise over $230,000 for SETBP1 disorder research and awareness. To help spread awareness, we released the SETBP1 disorder video, A Journey with SETBP1, earlier this year, and are working on our second video focused on SETBP1 Society and our researchers and medical specialists. We also strive to incorporate our families each step of the way. Our SETBP1 Society organization can use your help. We currently have volunteer opportunities for individuals with press release experience, We also have a need for regional patient leader volunteers. We want to build up our family communications and engagement and can use the help of different parents or caregivers to serve as the point of contact when new families join from certain regions. We're also looking for a patient leader coordinator who can work with me to help manage the regional patient leaders and help me build out this new area of support. Just send an email to info@setbp1.org to express your interest. And now, the moment you've all been waiting for. We are rolling out the red carpet for our SETBP1 kiddos. Many families shared photos and delightful details about their SETBP1Bs. Without further ado, let's meet these kids. This adorable 9-year-old boy named Cole is curious and expresses emotions deeply. He loves anything with wheels, especially old cars, exploring outdoors for bugs, and has challenges with global motor planning, learning new things, staying focused, and self-regulation. Next up, we have 13-year-old Antoine. He is a playful and social kid who loves everyone. He enjoys planes, trains, and trucks, and he rocks playing basketball, swimming, and camping. He's working on speech and developing better autonomy and social skills. This cute 12-year-old kid in his soccer uniform is John. He is a caring and affectionate kid who loves Legos, horses, skiing, riding his bike, and mini sports. He's also an adventurous eater, and he has challenges with attention and emotional regulation. Sweet and brave Evelyn is a 3-year-old who loves looking at cookbooks and helping in the kitchen. She's working on making new sounds, answering questions, and focusing for longer periods of time. John Parker is a 9-year-old boy who loves riding his bike, playing soccer, and kickball. He does not like schedule changes, and working memory and slower processing speed present challenges for him. Our youngest child diagnosed with SETBP1 disorder is Corey. He is currently 1 year old and loves popsicles, bath time, and being around other babies. He struggles with eating and motor skills due to his low tone. Alex is an affectionate and social 14-year-old. He likes riding a scooter and bike and playing on his iPad. He is currently working on speech and language, math, and handwriting. This loving and sweet 8-year-old is Colton, and he's also a fraternal twin. He loves video games, apps, swimming, and joking around. He's working on self-regulation and speaking in clear sentences. This young lady is Bella, and she's 17 years old. She loves playing on her iPad and watching movies and dancing. She's working on independent living skills and social skills. This little 3-year-old is June. She communicates with sign language and is a cheerful and sweet girl. She enjoys playing outside and puzzles, but shies away from crowds and new situations. Little Joey is a super social and silly 6-year-old who enjoys jumping in puddles in school. He has autism spectrum disorder and global motor planning challenges. Staying on task and following directions can be tricky for him. Little Sophie is a happy 8-year-old who loves attention. She enjoys singing and listening to music. Distraction, spontaneous language, articulation, and attention are challenges for her. Chase is a funny and good friend at the ripe old age of 11. He enjoys playing basketball and being a part of his choir and track and field team. He's working on self-regulation, fixation, and following multiple step instructions. This young man is Sebastian. He's 15 years old and enjoys farming, gardening, and cycling. He does not like loud noises or being indoors. Speech and a learning delay impact his daily living. This little 4-year-old is Katie. She likes playing musical instruments, hiking, and climbing. She communicates using her PEC system and is working on social skills. Thank you very much for this opportunity. Thank you, SETBP1 families, for joining us. It's been an honor to speak with you all. Be the hope, be the change.
Thank you so much, Haley, for that update. Just for everybody on the line, as I mentioned earlier, we are going to open up the line shortly to allow families to have some time together. But first, we had a late question for Dr. Sid that Dr. Sid said he's able to address. So I'll go ahead and just read the question. How can we determine if ADHD pharmaceutical intervention might be useful with a child who has severe developmental delay, no speech, no reading at 6.5 years old?
So that's a great question. And in that scenario, it can be difficult. I think the first question to ask is, does your child have the symptoms of hyperactivity, impulsivity that could even suggest that ADHD is a possibility? If ADHD is a possibility as a diagnosis, then the next kind of challenge is to see, well, is the level of hyperactivity or impulsivity or inattention, is that what you may expect from your child's cognitive level, or is it disproportionately affected compared to where your child may be cognitively? And that's a really, really tough and really, really challenging question to answer because, as you know, what is the norm? What are normative levels of attention and hyperactivity or activity levels for different age groups? I think that's a really difficult question to answer. But if that's something that's on your mind, you can also always consider a trial of, if there's symptoms of ADHD, if perhaps not, or it's and reaching a formal ADHD diagnosis may be challenging, you could consider a trial of a stimulant or a medication targeting ADHD symptoms. And what I mean by that is first deciding what are the outcomes you want to target. So do you want to, is it subjective improvement in behavior? Is it subjective improvement in schoolwork or academics? Can there be use of objective outcome measures such as an instrument, such as a checklist that a teacher may complete before and after starting the medication? So as with any trial, it's really good to have appropriate outcome measures so that you know if there's a response or not. Sometimes if you try a medicine and without having appropriate outcome measures in advance, then you don't know what you're targeting, what symptoms you're targeting, and it's hard to say, is there an improvement or not? So yeah, a tough situation, but there's certainly a couple different options you can consider, and I'm happy to talk offline in more detail.